We want to finish up by talking about a concern for everyone in the world, and that is COVID-19. And we know there are high-risk populations, the elderly, chronic obstructive pulmonary disease, patients on oncology treatments that are immunosuppressed. Rod, what are you doing with your MS patients in terms of steroids, and what advice about their multiple sclerosis medications?
Yeah, this is a really challenging topic for me. We've seen now about 5 patients with acute attacks with optic neuritis, and we've hospitalized a couple. We typically will give an option when we're dealing with acute optic neuritis for home health IV treatment. We've had very good success with that. Another option is infusion centers. We have several infusion centers, including one here at Baylor, across the street from where we are. And then the last is hospital admission. The fourth option that I hadn't really considered until now was there have been some papers that suggest, we talked about the quirky finding from the optic neuritis treatment trial where oral steroids were sort of a no-no because there was an increased incidence in recurrent optic neuritis in the same or fellow eye. But there have been some studies now that suggest non-inferiority between very high-dose oral prednisone, which we're talking around 1,250 milligrams. And if you do the calculations and you're using 20 milligram tablets, that's 50 some odd pills of prednisone, which is not easy to take. But nevertheless, patients have been treated with very high-dose oral and found to have similar visual outcomes to those treated with IV. I think the jury's still out on that, but I've had one patient now want to go that route because they didn't want to go into the hospital, they didn't want to go into the infusion center, and they didn't want someone coming into their home. So I think this is a reasonable option to consider in some patients in light of the pandemic.
Yeah. So the way many multiple sclerosis medications work are by limiting the activity of T cells or B cells, these two big populations of lymphocytes that have many subpopulations. The older MS medications, while I would call them immunomodulating, were not immunosuppressive, and I think are largely safe in the pandemic. And I've even put some people on those temporarily. They're excellent medications. And maybe we'll transition to one of the stronger medications in a year or so. The stronger medications are immunosuppressive or strongly immunomodulating. And the latest ones deplete B cells. B cells make antibodies. Antibodies can be bad, as we know in NMO. But B cells and gamma globulins can be very helpful in ridding you of a viral infection or other infections. So many of us now are postponing B cell depleting therapies in both MS and NMO patients until we know more about the virus, know more about immunity, and we have hopefully a vaccine within the next year or so. So I'm now recommending to patients that they hold off, if we can, with NMO B cell depletion and use steroids and pheresis. But we've had to move forward on one patient with that and take the risks with the virus, but very strict quarantine at home measures. All our patients on all these medications are followed with lymphocyte counts. And we really want to keep those counts over 500 if possible. So our surveillance system has increased even more in the COVID-19 era.